Yes, good evening. So, we are going to discuss the important 20 questions, which will be covering almost all the important high yield topics for this NEET PG exam. The first question, that is all are true regarding the telomerase, except see what the telomerase is doing is basically telomerase is the enzyme which is going to help us in the to reducing the end replication error. What is end replication error? Is basically when we do the replication, after the replication, the DNA is going to be slightly small. We lose some length of the DNA with every replication, which we don't want to happen. So we use the enzyme telomerase, and this telomerase is kind of attaching a dummy DNA towards the end of the 3 end. So when we are going to lose the DNA, we know that we are going to lose that. We are just going to lose the dummy DNA part. We will not lose the real DNA, the where we have the information, right? So all are true regarding the telomerase except the first is it is having a reverse transcriptase activity. Yes, it has a reverse transcriptase activity. Reverse transcriptase means from the DNA, when you make RNA, that is called as the transcription. But when you from RNA, you make DNA, this is called as reverse transcription. And it has reverse transcriptase activity. It's only found in eukaryotes. It maintains the chromosome length. Yes, that is the main function. The DNA fidelity is maintained. Fidelity means basically there is going to be proofreading. It is going to cross-check the things. No, the DNA telomerase is nothing to do with DNA fidelity. So this is not true. It's not true. The remaining statements are true. And now, can you tell me that what is the maximum limit that we have when we do the replication? What is the maximum number of the times when a somatic cell DNA can replicate? Because we know that after that the DNA will lose with every cycle. The DNA will lose its length. What is the maximum number of replication that we can do with one DNA in the somatic cell? We can do total 50 cycles of replication. Total 50 cycles of replication, and after that the DNA is so small that we can't do the replication. And this is called as which limit? This is called as Hayflick limit. It's called as Hayflick limit, right? The next question was a patient comes with the chief complaint of muscle weakness to OPD. Doctor found that he has cardiomyopathy and diagnosed him with Barth syndrome, where the patient's mitochondrial dysfunction. What is the defect in this patient? Actually, the diagnosis is already written, right? So it's a kind of a one-liner that Barth syndrome. Uh, what is the main defect? What is the basically Barth syndrome is a defect of cardiolipin. It's a defect of cardiolipin that is going to be there, and that will lead to the problem. In this, the cardiac muscle, the skeletal muscle, the mitochondria of these structures are not going to work because in the Barth syndrome, basically the cardiolipid molecule is not working, which is there in the mitochondrial membrane, and the mitochondria doesn't work, and that will lead to the muscle weakness as well as the cardiomyopathy. Now, in this option, one more option that is there was lecithin. Lecithin is related to surfactant, right? And if the lecithin is having the problem, the child will have the ARDS. That is the respiratory distress syndrome the child will have. So the lecithin is related to surfactant, cardiolipin is related to the mitochondrial membrane. A 20-year-old alcoholic malnourished patient presents to hospital with respiratory distress. His pulse was 112. Patient had edema, hypertension, systolic murmur along the left sternal edge. Bilateral capitation is felt in the lungs. The moment we see bilateral capitation in the lungs means there is pulmonary edema is there. Pulmonary edema is there, and there is some cardiac diseases there. So I would say that it's a cardiogenic pulmonary edema. At least we can figure out this much because the patient is having some cardiac murmur is also there. A diagnosis of congestive heart high output cardiac failure is made. It's a high output cardiac failure that is there, which vitamin is deficient. So basically, the high output cardiac failure can be seen with vitamin B1 deficiency because vitamin B1 deficiency can lead to beriberi. And beriberi is of two types, the wet beriberi and dry beriberi. And here they are talking about the wet beriberi, which is involving the cardiac system that is leading to the dilated cardiomyopathy, DCMP, where we will have the high cardiac output failure. And the reason for that is again the hint was here alcoholic malnourished, alcoholic patient, malnourished, not taking the proper diet. There is a very high chance of developing vitamin B1 deficiency. So it's a vitamin B1 deficiency. Plus, one more thing that you can figure it out here is that key vitamin B1 deficiency. Can you tell me that what other things that the vitamin B1 deficiency will lead to? What are the other things that the vitamin B1 deficiency will lead to? Vitamin B1 deficiency, yes, can lead to lactic acidosis. because vitamin B1 is required for the working of the pyruvate dehydrogenase complex. If the vitamin B1 is not there, the pyruvate dehydrogenase complex will not work. And what the pyruvate dehydrogenase complex is doing, see, the glucose converts into pyruvate. And when the pyruvate has two options, either pyruvate can convert into acetyl-CoA, or the pyruvate can convert into lactic acid. To convert the pyruvate into acetyl-CoA, we require the enzyme PDH complex. The PDH complex is having three subunits, E1, E2, E3. For E1, we require vitamin B1. So if there is vitamin B1 deficiency is there, the E1 will not work, the PDH complex will not work. So all the pyruvate will force to go towards the lactic acid, right? Now, can you tell me that there was a question in INCT that what is the common cause for congenital lactic acidosis? Which enzyme deficiency leads to congenital lactic acidosis? The answer was the PDH complex deficiency. If this PDH complex is not there by birth, again, the same problem will happen. That will lead to lactic acidosis. Now, guys, can you tell me that which anti-diabetic drug can lead to lactic acidosis? Which anti-diabetic drug can lead to lactic acidosis? Yes, it is going to be metformin. Which anti-diabetic drug can lead to? It is the metformin that can lead to lactic acidosis. Okay. The next is a single mutation in a nucleotide base pair, changing it from the protein coding to a terminating codon is known as what? Now, see, what is the meaning of terminating codon? Terminating codons are basically the stop codons, also called as the nonsense codons. And what are the nonsense codons? We have UAA, UAG, and UGA. Now, if a mutation happens, and because of that mutation, for example, here is the mRNA, and the codons are written on mRNA like this. And here is, for example, UAC. And here it is UAA, and the other codons are written AUG, CUG, CCU, something like this. So if this is the normal mRNA without any mutation, and if you do the translation of this, you will attach the first amino acid, then you will attach the second amino acid, then you will attach the third amino acid, then the fourth one. The moment the UAA will come, it's a stop codon. So the translation will stop here if this is a normal mRNA. Now, by chance, a substitution happens. Instead of C, now here comes the A. And if now the mRNA, how it will look like? It will be AUG, no problem, the same. CUG, no problem. But now it is UAA. There is a change. Now, if you do the translation of this, the first amino acid will attach, the second will attach, but now it's a stop codon. So the translation will stop here. It's a premature termination of translation that is happening. And this kind of mutation where a coding codon is converting into a nonsense codon or the terminating codon, this is called as a nonsense mutation. It leads to premature termination. It will lead to truncated proteins. It's going to be very severe one. So they're asking that what kind of mutation this is known as the nonsense mutation. Nonsense mutation. Right? It is going to make the proteins are going to be very small. Yes, very good. Now, where there is low insulin glucose ratio, which of the following enzyme is stimulated? Now, first thing first, what they want to say is by writing this statement that insulin glucose ratio, glucagon ratio is low. Means ratio is low means the insulin is low. We can say like this. So, which enzyme is going to be stimulated when the insulin is low? And this is one of the hot favorite topic nowadays of NetBoard about the lipoprotein lipase and hormone sensitive lipase. Now, can you tell me what is the answer? No. Okay. Now we are getting the mixed answers. So see here what these two enzymes are doing. Here is a representation of the blood. In the blood, we are having the chylomicrons bag, which are filled with triglyceride. Now, these triglyceride molecules are supposed to be given to the adipose tissue. To give the triglyceride to the adipose tissue, we require the enzyme that is lipoprotein lipase. And if you want to bring them back, if you want these triglycerides to come back to the blood, you require the enzyme that is hormone sensitive lipase. Insulin is the one that stimulates this thing. Insulin wants the chylomicron, the triglyceride to go to the adipose tissue. That is why insulin, we say it's a lipogenetic hormone. It leads to weight gain. The more the insulin, the more the triglyceride will go to the adipose tissue. Whereas if when we talk about the glucagon, The glucagon is going to stimulate this hormone. Glucagon stimulates the hormone sensitive lipase, or in other words, I can say the insulin is going to stop this hormone. Insulin is putting a brake on this hormone. Insulin never wants the triglyceride to go back to the blood. And here, what is happening is the insulin is low. This is what they have written. The ratio is low, means the insulin is low. If the insulin is low, means there is no brake. And if there is no brake, this enzyme will work more. This enzyme will work more. So this is what they're asking, that which of the following enzyme will be stimulated? The answer will be hormone sensitive lipase will be stimulated. Hormone sensitive lipase will be stimulated. Right? A person presented with the neurological manifestation mimicking the mimicking the UMN palsy and the sensory neuropathy. The patient was pale, and investigation revealed probable micronutrient deficiency. See, there are what are the findings that the patient is having? The patient is having the UMN features. The patient is having the sensory features also. It's kind of a mixed problem, and the mixed problem along with anemia. Now, this has made the question very easy. Even if this anemia word would not have been written, then also we should have be able to give the answer. They are talking about SACD, subacute combined degeneration of spinal cord. Now, when it comes to combined, means there can be UMN feature, LMN features, sensory features, because when it comes to the subacute combined degeneration, here is a cross section of the spinal cord. Here we are having the corticospinal tract. Here we are having the anterior horn, the dorsal column, the spinal thalamic tract. So we have the sensory, we have the motor areas, we have the UMN areas. This is the UMN area. The anterior horn is going to be the LMN area. Anterior horn is going to be the LMN area. So now what is happening is there is a problem in this area, this area. So there's going to be random problem that is going to happen. And that is seen with the vitamin B12 deficiency. So they are talking about SACD. It is due to what? It is due to vitamin B12 deficiency, and that leads to anemia also. Can you tell me which anemia? Yes, it will lead to megaloblastic anemia. And in the megaloblastic anemia, we are going to have the hypersegmented neutrophils. Hypersegmented neutrophils. One more thing that is going to happen. Can you tell me that if the vitamin B12 is not working, which enzyme will not work? There is going to be deficiency of which enzyme activity? Vitamin B12 is required for which enzyme activity? Vitamin B12 is required for methylmalonyl-CoA mutase. If the vitamin B12 is not there, this enzyme will not work. And if this enzyme will not work, what is going to happen with the level of methylmalonyl-CoA? The methylmalonyl-CoA levels will increase, because this mutase is the one that is converting the methylmalonyl-CoA into the succinyl-CoA. If this enzyme is not working, the methylmalonyl-CoA is going to increase. So that could have been also asked in this exam, in this question, right? That they might have asked about that, what would happen with the methylmalonyl-CoA level, or which enzyme activity is going to reduce. Yes, it is the methylmalonyl-CoA. Very good, Anuj. Very good, Dhananjay. The next is a 2-year-old child presents with vomiting, lethargy, irritability following a high protein meal. The blood test reveals hyperammonemia and elevated levels of orotic acid. Which enzyme deficiency is most likely to be there? Now, here is a very clear-cut question that there is increased amount of orotic acid along with hyperammonemia is there. There is increased amount of ammonia, means there is hyperammonemia along with orotic acid. This is, they are talking about hyperammonemia type 2. Hyperammonemia type 2. It is due to deficiency of which enzyme? It is due to deficiency of ornithine transcarbamylase. This deficiency of ornithine transcarbamylase. Plus, if this question would have written just like this, the first line, but they have not mentioned about the orotic acid, they would have written that normal orotic acid. Then we should think of hyperammonemia type 1, because in hyperammonemia type 1, there is only and only increase in ammonia. There is no orotic acid. If hyperammonemia type 1 we talk about, it is due to deficiency of which enzyme? It is due to deficiency of CPS1. And if I ask you that, in the same question, if I say there is increased amount of ammonia, there is increased amount of ornithine is mentioned, there is increased amount of homocytolin is mentioned. Can you tell me that this is called as which disease? If there is increase in hyperammonemia, hyperornithinemia, and homocytolinemia is there, then the answer would have been what? Yes, then the answer would have been triple S syndrome. Triple S syndrome, hyperammonemia, hyperornithinemia, homocytolinemia. And it is due to defect of what? It is due to defect of ornithine transporter 1. Only transporter 1. And what can be one more buzzword in the triple S syndrome? Because there is more ornithine will lead to gyrate atrophy. There is going to be a problem in the retina. There is going to be gyrate atrophy, the gyrate atrophy, right? So that is how we'll figure out. But the most important, and because the most common hyperammonia is type 2, the most common hyperammonia is type 2, so that is again going in the favor of that. And orotic acid level scientist, that is very classical with hyperammonia type 2. A 40-year-old male presents with the recurrent episodes of pancreatitis and is found to have elevated level of the chylomicron. Triglycerides are more. Normal cholesterol level. Which of the following lipoprotein abnormalities is most likely? See, the pancreatitis is basically one of the reasons of pancreatitis is hypertriglyceridemia. And they have mentioned already that the chylomicron is more. We know that inside the bag of chylomicron, there is exogenous triglyceride is there. And if the triglyceride which type of disease? It's a familial, it's an autosomal recessive disorder where the lipoprotein lipase is deficit. So this is called as a familial hyperchylomicronemia. Familial hyperchylomicronemia. But can you tell me that familial hyperchylomicronemia can be seen with the lipoprotein lipase deficiency, or it can also be seen with deficiency of which protein? It can also be seen with the deficiency of ApoC2, because ApoC2 is the one that actually stimulates the lipoprotein lipase. So if the ApoC2 is also not there, the lipoprotein lipase will not work. So familial hyperchylomicronemia can be seen with the deficiency of lipoprotein lipase, or can be also seen with the ApoC2 defect. If the ApoC2 is not working, the lipoprotein lipase will not work. And again, we'll have the same picture, right? So the same thing that is going to be there. A new drug inhibits an enzyme to bind a site, then the active site, and reduce the maximum rate. Which type of inhibition this drug most likely represents? Now, what they are saying is that the inhibitor, this is a drug which is an inhibitor, it binds to a site other than the active site of the enzyme and reduces the Vmax. See, on the enzyme, we have the two sites. For example, here is the enzyme. You can see two sites. One is the active site where the substrate is going to attach. And now they are saying that the inhibitor is not attaching, it is attaching somewhere else. It would have been attaching here, that is the allosteric site. Now, if something attaches on the allosteric site and it changes the shape of the active site, now the substrate cannot attach. And this type of inhibition is called as the non-competitive inhibition. Non-competitive inhibition. Can you help me with the answer that in non-competitive inhibition, what is going to happen with the Vmax? What is going to happen with Vmax? What is going to happen with the Km? In the non-competitive inhibition, the Vmax is going to reduce and the Km is going to remain the same. And this is what they have written, that the maximum rate of reaction is reduced, the Vmax is reduced. So we are going towards a non-competitive inhibition. Non-competitive inhibition. But let's give me the other answers also. In the competitive inhibition and the uncompetitive inhibition, what happens with the Vmax and what happens with the Km? In the competitive inhibition, the inhibitor and the substrate both will fight for the active site to reach, right? And in the competitive inhibition, you can reach to the Vmax. If you increase the concentration of substrate, you increase, you can reach to the Vmax. But in that process, the Km is going to increase. Whereas in the uncompetitive, we can't reach to any of them. And just now we have discussed about the non-competitive inhibition. The Vmax we can't reach, but the Km will remain the same. So this box is very, very important for this exam, right? That they always ask about these things, that what is going to happen with the Vmax, what is going to happen with the Km in the different scenarios. Then the next question is, which of the following amino acid is both ketogenic and glucogenic and also contains a hydroxyl group in its side chain? So basically they are saying that which amino acid contains hydroxyl group, right? The hydroxyl group containing amino acids. The hydroxyl group containing amino acid means the alcohol containing amino acid. Can you tell me some of them? Yes, the mnemonic was Cert-Haro, that is serine and threonine, and one more was tyrosine. And now they're asking that out of these three, which is having the property of keto plus glucogenic both. Mostly the keto plus glucogenic is the one which are aromatic, right? This is how we have remembered, right? So all the three, they are having the hydroxyl group, but these two, they are glucogenic only. Tyrosine is aromatic, so it is keto plus glucogenic both. So they're asking that if it's the one that is hydroxyl group with keto plus glucogenic, it is going to be tyrosine. It's going to be tyrosine, right? Now, can you answer me some more questions then? Let's do a rapid fire of the classification of amino acid. Can you tell me that what are the simple amino acid that we have? What are the simple amino acid that we have? Is Ga, glycine and adenine. Ghana is a simple thing to do. Can you tell me the branch chain amino acid? The branch chain amino acid, it is leucine, isoleucine, valine, live. Then the sulfur containing amino acid. The mnemonic was methycyst. Methycyst. What is there inside the methycyst? Sulfur. Then what are the acidic amino acid? The acidic amino acid will have the negative charge, that is aspartate and glutamate. What is the basic amino acid? The positively charged amino acid. The mnemonic is his last urge is very basic. Histidine, lysine, arginine. His last urge is very basic. His last urge is very basic, right? It's good. Very good. Let's move to the next one. In Parkinson, there is loss of dopaminergic neurons that primarily affects which enzyme activity in substantia nigra, contributing to motor symptoms. See, we know that in Parkinson, there is decrease in the dopamine. And how the dopamine is made? Dopamine is made from tyrosine amino acid. Tyrosine converts into dopa, and then the dopa converts into dopamine. Now, to convert the tyrosine into dopamine, the main enzyme, the rate limiting step for this entire event, the rate limiting step is going to be tyrosine hydroxylase. The rate limiting step is going to be tyrosine hydroxylase. So in Parkinson patient, this tyrosine hydroxylase, if it will not work, then the dopamine will not be made. There is going to be decrease in the dopamine. And this is what actually happens in Parkinson's patient, right? In Parkinson, there is loss of dopaminergic neurons in the substantia nigra because the tyrosine hydroxylase enzyme is not working. So we can't make the dopamine, and dopamine deficiency is the one that is leading to the motor symptoms of the Parkinson. When it comes to the MAO-B and COMT, what these enzymes are going to do is basically the MAO-B and COMT, they are going to destroy the dopamine. Once the dopamine comes out of the neuroterminals, the dopamine, once it comes in the synapse, from here to remove the dopamine molecule, the MAO-B and COMT enzyme is going to work. So their activity is not going to be decreased. If their activity decreases, it's good for Parkinson actually, because that is going to increase the dopamine level, because these are the enzymes which are eating the dopamine. In the Parkinson's disease, these enzymes works more. So basically the dopamine is reduced, right? So they are asking that which enzyme is mainly affected. The mainly affected is going to be the tyrosine hydroxylase. That is the one that is the rate limiting enzyme to make the dopamine molecule. A patient is having xanthomas and elevated serum cholesterol and is found to have a deficiency in the receptor essential for LDL uptake. Now, which of the following is the most likely defective? See, this patient is having the LDL receptor defect. The LDL receptors are made up of the protein ApoB100. Now, what this ApoB100 is doing is, for example, here is the bag of LDL and here is the tissue which really wants the cholesterol to consume. This bag of LDL contains a receptor that is B100. With the help of B100, the cholesterol will be delivered here and the cholesterol consumption happens. But by chance, if this is defective, then the cholesterol consumption cannot happen. The cholesterol will remain here in the bag of LDL only, and that is going to remain in the blood. That is going to increase, and then it will this cholesterol will deposit at different places, maybe in the blood vessels, maybe in the eyelids, leading to atherosclerosis, leading to tendon xanthomas, xanthelasmas, and this is what is happening. The xanthomas are there. The elevated serum cholesterol is there. It is due to defect of what? It is defect of B100. And what is the name of this disease? Can you tell me that? This is which number lipid disorder it is? It is which number lipid disorder? Yes, it is the the type 2 lipid disorder. This is the familial hypercholesterolemia. And can you tell me one more thing, that it is going to be, what is the inheritance pattern of this? What is the inheritance pattern? The inheritance pattern is going to be the autosomal dominant. This is the only lipid disorder which is autosomal dominant. The remaining, the lipid disorder, the type 1, 3, and 4, they are going to be recessive. Yes, very good. The next is a patient presented with hepatomegaly, fasting hypoglycemia, and increased blood lactate levels. The liver biopsy shows the glycogen accumulation with abnormal glycogen storage structure. Which enzyme deficiency is most likely? Now, see, the moment you see hypoglycemia in a child, or the hypoglycemia in a quotient where they are talking about glycogen storage disease, there are two diseases that should come in your mind: the von Gierke disease and the Cori disease. Actually, Cori is basically is a mild version of von Gierke. In von Gierke, there is severe hypoglycemia. Cori will have mild hypoglycemia. Now, what is the additional finding that is there? Von Gierke is due to deficiency of glucose 6-phosphatase enzyme, whereas Cori is due to defect of the debranching enzyme. Debranching enzyme is not working. That is Cori. So in both of them, the glycogen cut down is not happening. In the first one, the last step is not happening, whereas in Cori, the debranching enzyme is not working. So because the debranching enzyme is not working in Cori, what we will notice is that the glycogen, to remove the branch, we require the debranching enzyme. If the debranching enzyme is not there, the cutting will not happen. It's not that the cutting will not happen at all. The cutting will happen, but the cutting will stop here. And this short branched glycogen will accumulate in the liver. This short branched glycogen is going to accumulate in the liver. This is abnormal glycogen. So they are asking that the patient is having hypoglycemia. The moment they say hypoglycemia, there are two things come in my mind: von Gierke and Cori. And because they have said that the abnormal structured glycogen is there, that is the short branch glycogen is there, then the answer is going to be debranching enzyme deficiency. They must be talking about the Cori disease. Cori disease. Plus, in von Gierke, what are the other things that is going to be there? In von Gierke, there is increase in the lipid levels. There is increase in the uric acid levels. So these additional features will be seen in von Gierke, hyperlipidemia, hyperuricemia, that is seen in von Gierke. Right? Let's move to the next question. So good, very good. A patient presents with hyperuricemia. It was an easy question, guys. It was an easy question. Hyperuricemia, self-mutilation, developmental delay. The moment you see self-mutilation, what is coming in your mind? The Lesch-Nyhan syndrome. Now, till this point, it was looking easy. But the moment I looked at the options, that they are asking not about the diagnosis, they are not asking about the name of the disease. They are not asking the name of the enzyme deficiency. What they're asking is that enzyme is found in which pathway actually. Lesch-Nyhan is related to HGPRTS deficiency. And HGPRTS is an enzyme which is related to the recycling of the purines. Recycling of the purines means it is related to the purine salvage pathway. It is related to the purine salvage pathway. So the question, when I was reading the question, it was looking very easy, right? The cell mutilation word was there. The moment you see cell mutilation, the exam also this happens many of the times. You may have felt that when we see just the question, we are happy. But the moment it comes to the option, it changes the things, right? Because we were thinking that we were having the answer, the Leschnia, the LSGPRTS, we should go with that, but they have asked not the names or the diagnosis of the enzyme, the purine salvage pathway, right? Okay, it's very good. And you have answered correct also about this pathway also. It's very good. Let's move to the next one. A young adult presents with hepatosplenomegaly. Just young, it's not adult. Around 8-year-old boy. This is what is the data that is there. The presenting with hepatosplenomegaly. He's having pancytopenia. The bone marrow biopsy reveals the presence of lipid-laden macrophages are there. Which enzyme deficiency is most likely to be there? Because they have talked about hepatosplenomegaly, there's something is accumulating in the liver, in the spleen. Plus, there's something is accumulating in the bone marrow also. That is why the pancytopenia is there, right? The lipid-laden macrophages. Some lipid is accumulating in the bone marrow, that is accumulating in the cells also. The lipid-laden macrophages are there. Which enzyme deficiency? Actually, they are talking about Gaucher disease. Because in Gaucher disease, we are going to have the hepatosplenomegaly. We are going to have the pancytopenia. Pancytopenia. The moment I will see this, I should think of the Gaucher, and Gaucher is due to deficiency of what? It is due to deficiency of the beta glucocerebrosidase. Beta glucocerebrosidase. So they are talking about the glucocerebrosidase deficiency. And this lipid-laden macrophage, what is going to happen is actually the cytoplasm will look like as if there are white, crumbled tissue paper appearance will be there. So basically they are talking about this crumbled appearance of the cytoplasm. This question would have been easy if the image of the crumbled tissue paper appearance of the cytoplasm was given. But let's look at the other options also. Sphingomyelinase deficiency, it's the Niemann-Pick disease. And in Niemann-Pick disease, they would have talked about cherry red spot on the retina. Cherry red spot. There is going to be vertical gauge paralysis will be there in Niemann-Pick disease. Alpha galactocerebrosidase deficiency. If there is deficiency of alpha leads to Fabry. We have remembered like this, alpha galacto, it's related to Fabry. Alpha, Fabry. Right? If they want to ask you about Fabry disease, Fabry is X-linked recessive and it will lead to angiokeratoma. This word would have been given in the MCQ, angiokeratoma. The moment you see angiokeratoma, you should think of Fabry. Hexosaminidase A deficiency will lead to Tay-Sachs. And in Tay-Sachs, there is going to be the cherry red spot, but no hepatosplenomegaly. So this cannot be the answer automatically because there is hepatosplenomegaly was mentioned. So this cannot be the answer. Right? It's very good. A patient on antiretroviral therapy for HIV develops lactic acidosis. Which mitochondrial enzyme is most likely inhibited by this drug? Actually, we have discussed the same concept when we have discussed the earlier question about the beriberi, the vitamin B1, if you remember. See, what happens is, sorry, the glucose that we are eating, the glucose converts into pyruvate. The pyruvate is having two options. It can convert into lactic acid or can convert into acetyl-CoA. To convert the pyruvate into acetyl-CoA, we require the enzyme that is PDH complex. What this drug must have been doing is that drug must have been stopping the PDH complex. If you stop the PDH complex, the pyruvate will be forced to go towards the lactic acid. So they're asking that this patient is having lactic acidosis, so he must be having the defect in which enzyme? It is the pyruvate dehydrogenase complex. Pyruvate dehydrogenase complex. Yes, good. It's very good. A 50-year-old male presents with weakness, fatigue, and chronic alcohol use. Laboratory finding finds increased level of methylmalonic acid. The concept we have already discussed about this. See, vitamin B12, what the vitamin B12 is doing is, it is helping in the enzyme activity that is called as a methylmalonyl-CoA mutase. And what this enzyme is doing is, it is converting the methylmalonyl-CoA to succinyl-CoA. If the B12 deficiency is there, this enzyme will not work. And if this enzyme will not work, there is going to be increase in the methylmalonyl-CoA levels. And this is what they are seeing. In the chronic alcoholic patient, because they don't take proper diet, so there is very high chance of happening that. And we already have discussed about that, right? The vitamin B12 deficiency will have increased level of methylmalonyl-CoA. We have also discussed that B12 deficiency will lead to SACD also. But can you tell me that which parasite loves to eat B12? If that parasite is there in your intestine, that will eat out all the B12. Yes, that is the fish tapeworm, the D. latum. Fish tapeworm loves to eat the vitamin B12. Plus, to find out the vitamin B12 malabsorption, if the vitamin B12 malabsorption is happening, which test you are going to do? We are going to do the Schilling test. Schilling test is done to find out the vitamin B12 malabsorption cause. Right? Very good. Very good. A patient presents with hemolytic anemia, jaundice, a positive osmotic fragility test. The moment we see osmotic fragility test is positive, means the RBCs are not able to tolerate the hyperosmolar environment. Normally, the RBC can tolerate, but if the RBC membranes are not made properly, and if you put that RBC in the hyperosmolar environment, the RBCs will burst. And in which disease the RBCs are not made positively, they are not made properly, and they will burst, right? In the hyperosmolar, that is the hereditary spirocytosis. That is the osmotic fragility test that we do for. Now, if you see the other causes also, they are also leading to hemolytic anemia. G6PD, pyruvate kinase deficiency, PNH, they all are leading to hemolytic anemia. In the G6PD, what will be the hint in the MCQ? That when the person is taking some drugs, the free radicals are killing the RBCs. If the free radicals are killing the RBC, that is going to be G6PD. And G6PD is going to be the X-linked recessive disorder. It means that is mainly going to affect the males. Pyruvate kinase deficiency, it also leads to hemolytic anemia. In fact, that is the second most common cause for the hemolytic anemia that is there is the pyruvate kinase, because if the pyruvate kinase will not work, it's an enzyme of the glycolysis. So the RBC can't do glycolysis then, and the RBC cannot survive without glycolysis, because the only source of energy for the RBC is glycolysis, and this is a glycolytic enzyme. The glycolysis will not happen if this enzyme is not there and the RBC doesn't survive. But there is nothing to do with the osmotic fragility test, right? So the osmotic fragility test, it is related to hereditary spherocytosis. It's good. A patient presented with the chronic granulomatous disease. Which of the following enzyme deficiencies is the most likely associated with this? See, the chronic granulomatous, the CGD. CGD is basically defect in the enzyme NADPH oxidase, because that is the enzyme which is going to help in the prevention of the granulomas. If this enzyme is not there, the granuloma formation will happen, and they will happen continuously. That is a chronic granulomatous disease. These patients will have less immunity. So they will have recurrent infections with a lot of granulomas. They are talking about CGD, the chronic granulomatous disease. And it is due to the effect of which enzyme? NADPH oxidase. It's good. Yes. Now here comes the last question. A 25-year-old male presents with recurrent episodes of fasting hypoglycemia. Fasting hypoglycemia is there. The hepatomegaly is there. There is increased level of serum transaminase. The SGOT, SGPT, they are increased, means something problem is liver is going on. There is a liver defect. There is some problem in the liver. There is some liver pathology is there. The mutation reveals that the liver isoform of phosphorylase kinase is not working. There is a mutation in this. Now, here is basically the question of the language. What is the liver isoform of phosphorylase kinase? Phosphorylase kinase, basically, now, if we were not able to figure out this statement, let's write down the names of the enzymes. What is there? The Cori disease is due to deficiency of D branching enzyme. Von GRK is due to deficiency of glucose 6 phosphatase. McArdle's is muscle glycogen phosphorylase or muscle myophosphorylase. And Her's disease, H for her, it is the hepatic phosphorylase. So they are asking the liver form of phosphorylase is not working. Now, instead of hepatic phosphorylase, they have written the word liver phosphorylase, right? That is the same thing. And that is basically a defect of the type 6, that is the Hertz disease, where the liver is not able to consume the glycogen at all. It's not able to cut, and the glycogen itself is going to accumulate. See, what happens is normally in the liver, the glycogen which we are having, the first enzyme that is going to help in the cutting is the hepatic phosphorylase. And if this is not there, the glycogen will not cut in the liver, and that will accumulate, and that will lead to hepatomegaly. And this is what is happening. This patient is having hepatomegaly with hypoglycemia, and they are asking, they have written itself clearly that plus along with that, the clinical integration. So I am anticipating that because these are the actually in biochem, there are very less clinical vignettes that can be framed, and these are the important clinical vignettes that is there. So at least if you go through these clinical vignettes, that most of the clinical question that is going to come that will be taken care. Plus the important one liner point that also has been mentioned, they are very high, right? It is, the exam is just around the corner. It is the correct mindset that is going to make a huge difference in the exam. As far as the biochem subject is concerned, the biochem gives basically is a subject which decides a lot of things in these exams, in the competitive exam, because most of us are afraid of the subject of biochem. Those who are having the biochem as a strong subject, they always have extra edge, because this is the subject where you can answer the maximum correct question. If 12 14 questions will come, this is the subject where we can score almost 100%, because the things that they ask in this exam is more or less with a similar pattern, right? So if you have, Anuj is asking that what is a decent score that would have been here. If you have scored anything be above 16 is a very decent score. It's a very good score that you have, because there were few questions, they were very tricky. The language was tricky, right? So, and in the given limited time frame, if you have able to score more than 16, then it's wonderful score that you have achieved, right? So, guys, wish you all the very best. And this is just not for the NEET PG exam. This is also important for the FMG exam and the upcoming any competitive exam which you are preparing for. Right. So, wish you all the very best and thank you. It's a good night, guys.